The next topic we're going to be looking at is the genetic aspects of congenital heart disease. And really, in half an hour, this is going to be a pretty rapid tour for some of the genetic considerations and syndromes that we consider when evaluating a fetus with a structural heart lesion. Again, my disclosures are no different than previous. I provide educational support to GE Healthcare. So congenital heart disease as an entity is really known to have a fairly strong association with aneuploidy syndromes, single gene disorders, as well as copy number variants or variants of uncertain significance. Now, the extent to which this association exists obviously differs by lesion, but overall the association is strong. And this association actually gains strength as our ability to do more refined genetic testing increases. Genetic basis for this was likely very underestimated previously, when all we had to rely on in our armamentarium was a standard karyotype looking for large numerical abnormalities. But as we're now using more refined things like microarray, next generation sequencing, etc., it becomes clear that the genetic associations were far underestimated and probably much more significant than previously expected. There's also a really new, significantly strengthened association with what are referred to as RASopathies, which we'll get into shortly, as well as other issues like ciliopathies, including heterotaxy. I remember not too many years ago where heterotaxy was really thought to be a random event without a terribly high risk of recurrence, and our knowledge of that is now changing dramatically. Now, the first thing to remember is that not all congenital heart lesions are created equal. Some are significantly more syndromic, quote unquote, than others. And two really good examples would be tetralogy of Fallot or an AV septal defect. So, for instance, things to consider specifically with a TET would be isolated, obviously, but strong association with trisomy 21, 18, as well as 13, the conotruncal abnormality that is characteristic of DeGeorge syndrome, including 22q deletion, Alagille syndrome, Charge syndrome, and many, many others. An AV septal defect can also be isolated, but carries again a strong association with trisomy 21, multiple other syndromic associations, including heterotaxy and PCD, and overall require you to think a little bit outside the box, or rather outside the heart, to help you with these diagnoses. Now, again, the breakdown is probably a lot different than things that you would look at up to 10 or 15 years ago. There's a really good review article published in 2018 in Circulation by Pierpont et al., looking at really the genetic basis of congenital heart disease. And our contemporary knowledge suggests that this is probably the best breakdown. A genetic or environmental defect overall probably accounts for 20 to 30% of disorders, but it can shake down with these other additional findings, with single gene disorders in the range of 3 to 5%, gross aneuploidy or structural chromosome anomalies 8 to 10%. But look at the remainder of things that we probably had very little ability to look at before, including pathogenic copy number variants associated with syndromes, or isolated copy number variants that have been deemed pathogenic due to sufficient reports associating that particular variant with a specific phenotype. We also have small numbers of de novo autosomal dominant, inherited recessive, and environmental or teratogenic. Now, if you look at the specific cardiac lesion, and again, this is a great guide from Alfred's textbook, the association of chromosome aneuploidy with congenital heart disease again differs by lesion. Kind of similar to the slide I showed you a few slides ago, but really looking at all of the specific lesions. Really down at the bottom, we have the ones that are very strongly associated with an underlying chromosomal abnormality. And these include at the highest parameters, including AVSD, but then ASD, VSD, double outlet right ventricle, tetralogy of Fallot, etc. At the upper portion of the graph, we have those that are rarely associated with chromosomal aneuploidy, which I think most people are familiar with, including the two forms of transposition and pulmonary atresia without VSD. Now, the extent to which you identify an underlying genetic origin depends on what tools you use. And you can think of your testing or your DNA-based testing really in terms of two specific groups. Genomic, where you're looking at the whole fetal genome, looking for numerical abnormalities, types of variation at all locations within the genome, or targeted, where you may have some basic idea as to what you're looking at, and you're using the targeted testing to test a specific hypothesis about one or several genes or loci that are involved in the disease. So if we look at our genomic testing, that would be a karyotype, which is helpful for aneuploidies and large rearrangements, or a genome-wide array, here comparative genomic hybridization, which is going to give us, of course, information about gross numerical abnormalities, but also copy number variation across the genome. What these two do not help us with particularly are single nucleotide polymorphisms, as well as insertions and deletions that do not result in a net loss or gain of DNA. If we look at the more targeted panels that we typically use, a FISH, which would be, for instance, a deliberate 22q FISH that you're looking at to assess a specific fetus, or a targeted gene panel, for instance, a Noonan panel or a hypertrophic cardiomyopathy panel. And these give us very little information about whole chromosomal aneuploidies, but a lot of information about the subchromosomal information for specific genes that include mutations or deletions, etc. Exome sequencing and genome sequencing are supposed to give us broad genetic information across the entire genome, and these are used sometimes where previous testing has been negative or uninformative, and can be helpful to look for variants, insertions, deletions, etc., that have not previously been reported to be pathogenic. Understand that there's overlap between these two. Oftentimes we will sometimes use a combination of both targeted and genomic, and this will be one of the things that I discuss in my case presentation. Now, chromosomal aneuploidy and congenital heart disease, or as well as syndromic associations in congenital heart disease, is probably beyond the scope of this talk, but we're going to give some attention to some of the more common disorders that we encounter. Obviously, in terms of chromosomal aneuploidy, trisomy 21 and Turner syndrome are very common. I mentioned 13 and 18 briefly, only to keep in mind that congenital heart disease is common in these disorders, but I'm not going to spend too much time on them owing to their lethality. As far as other syndromes, we're going to touch on 22q, Vacteral, Holt-Oram, and Noonan/Rasopathy, keeping in mind that, again, this is by no means an exhaustive list. Now, in terms of Down syndrome or trisomy 21, remember that this is the most common chromosomal aneuploidy associated with congenital heart disease, in that roughly half of fetuses with trisomy 21 will have some element of congenital heart disease. Remember again that most Down syndrome is due to pure trisomy 21 or a third copy of number 21, but may rarely in 1 to 2% of cases be due to an unbalanced translocation. Now, congenital heart disease is responsible for 13% of childhood and 23% of adult deaths in individuals with trisomy 21. And we see varying types of congenital heart disease, including the hallmark defect that people are aware of, which is the AVSD or AVSD with tetralogy. But all of these features are seen to a greater or lesser extent in individuals with trisomy 21. Now, really just to go over some of the early markers again, remember that in the first trimester, there are lots of things that are helpful, including an increased nuchal translucency, an absent or hypoplastic nasal bone, and if you're a little bit of an FMF dork like I am, you're also going to be looking at these fetuses for evidence of abnormal ductus venosus waveforms, so here we have a reversed A wave, as well as the presence of tricuspid regurgitation, which in the first trimester is defined by at least half of systole and at least 80 centimeters per second. You may also see nasal bones in terms of unilateral hypoplasia, which we can see here in this 12-week fetus where we have a present nasal bone on one side and an absent nasal bone on the other. It's also a really good time early in pregnancy to remember that you can get a lot of information just about four-chamber view defects. So here we have a 12 or 13-week fetus at the time of a nuchal translucency, which shows clear evidence of a complete AV septal defect. And you'll also notice that there's an echogenic focus in the left ventricle. Now remember that oftentimes your clue to the presence of AV septal disorders is this linear insertion of the AV valves. And here you can see again a fetus with a complete AV septal defect. Notice we have no valvar offset. Now, other features that we see, I've stayed away from some of the more common ones that people appreciate, like echogenic focus, really to draw your attention to some of the extracardiac features, including things like thickened nuchal fold, which was really the first published marker for Down syndrome screening. Things like small jugular lymphatic cysts, and if you see these in a fetus, it really behooves you to turn on color and confirm that you're dealing with a lymphatic and not a vascular malformation. These fetuses tend to have some pretty typical facial features. Generally, there's a flattened profile or midfacial hypoplasia. There's often a little protuberance of the tongue and droopiness of the lower lip, which is due to the generalized hypotonia. Here you can actually see the flattened midface and the epicanthal folds on this fetus. And again, here's just a 2D rendering, protuberant lower lip, very little projection to the midface, although there is a nasal bone visualized on this baby. In a similar profile, you may also appreciate a little bit of the frontal edema. This is referred to as a prenasal thickness and is measured between the skin on the forehead and the junction of the nasal bone and the frontal bones. Down syndrome fetuses may occasionally demonstrate hepatomegaly, and the easiest way to measure this is the greatest longitudinal diameter of the liver from the diaphragm to where you see it lowest in the abdomen. The most likely reason for this in affected fetuses is that they may have transient leukemoid reactions, and this is what you see as a consequence of extramedullary hematopoiesis. Looking at hands, you may see a couple of telltale features. Clinodactyly is one that people talk about often, which is where we see incurving of the little finger. But typically, this is about the point in time where everybody in the audience looks at their own fingers, and you realize that this is prevalent in a lot of normal individuals as well. The more specific feature is the hypoplastic or absent middle fifth phalanx on an affected fetus. Now, one of the things that, again, I look for on every baby I see in the first trimester at nuchal translucency time, and certainly in the second trimester, is for the presence of an aberrant right subclavian artery. And really what this is, it's an arch variant where instead of having your right subclavian artery originate off the first branch or the brachiocephalic artery here, it originates as a discrete fourth branch off the aortic arch and courses most typically behind the esophagus and trachea towards the right fetal shoulder. Now, as an isolated finding, this has a likelihood ratio of approximately 3.9 for Down syndrome. When it's seen in conjunction with other conotruncal abnormalities, it markedly increases the risk of 22q deletion, but it is seen in approximately 1% of normal fetuses as well. That changes to roughly a quarter of fetuses with trisomy 21. Now, when you see this as an isolated feature, management is a little bit controversial, but since we have such ease of testing non-invasively for 22q, I would suggest that that's probably a minimum thing to offer the patient. When you see it in conjunction with other anomalies, obviously we're shifting more towards a diagnostic testing profile. And here's an example of an aberrant right subclavian artery. Here we have our three-vessel tracheal view, so main pulmonary artery, ductus, transverse aortic arch. The trachea is seen as a sonolucency here in the middle, and here we have this vessel coursing towards the right fetal shoulder that runs behind the trachea and usually esophagus. Let's move on to Turner syndrome or monosomy X. This is an abnormality that we commonly pick up early in pregnancy, and it's picked up really largely on a referral basis, at least for me, of fetuses with cystic hygromas or increased NTs. They may also show some facial edema as well as effusions and hydrops in the most severely affected. If they survive into late gestation and you're able to get good facial anatomy, you may see posteriorly rotated low-set ears. I know in various talks, Alfred has a wonderful picture of a fetus with dorsal pedal edema. But from a cardiac standpoint, really what you're looking for is any evidence of significant to even subtle left-sided cardiac obstruction. So I had a run on these particular babies last year. I have at least 3 or 4 in the 8 to 9 week period with bilateral pleural effusions and some edema that were subsequently proven to have Turner syndrome. And here you can see in a clip, we're at the level of, in theory, the 4-chamber view, even though we can't pick up 4 discrete chambers, but we have bilateral pleural effusions. And here's just a silhouette rendering, again, of the fluid within the chest. Now, the more typical appearance later on in pregnancy at the time of 12 to 13 weeks is that you'll see these fetuses with these enormous septated cystic hygromas, which really oftentimes extend towards diffuse truncal edema, marked subcutaneous edema, almost everywhere except the limbs, which are typically spared. So I put this slide up, also this clip, to remind you that omphalocele are a well-reported feature of Turner syndrome. They're not that common though, and sometimes they send you for a loop thinking this can't possibly be Turner's because I see the bowel-only omphalocele. But remember that it is well-reported within the phenotype. Here you can also see this baby has diffuse subcutaneous edema as well. Now in this slide, before I start the clip running, all of this echogenic junk around here is really this diffuse edema that is around this fetus's chest. Here we're going to see the heart start to move. Obviously this is the anterior right ventricle. You're getting little glimpses of the RVOT. And the posterior ventricle is already considerably undersized or smaller. Using Z-scores on this baby, you can see that the left ventricular diameter is already less than -6 on a Z-score scale. And later on in gestation, you may see this more markedly. Again, all of this is just this massive typical edema of Turner syndrome. Here we have bilateral pleural effusions, and here a really non-visualized left ventricle consistent with a hypoplastic left. Now, if these fetuses don't succumb to hydrops, and remember there's a really high rate of prenatal loss for fetuses with Turner syndrome, your features into the 2nd and 3rd trimester may be some of those limited to things that are associated with coarctation. And that may be something like a smaller left ventricle with a muscle-bound larger right ventricle, or even limited to things like a bicuspid aortic valve. So the spectrum of left-sided heart disease ranges from severe and a hypoplastic left ventricle to even just a bicuspid valve. Now moving on to the VACTERL association, This is a little bit of an outlier for a genetics talk in the sense that we speak about this as an association, meaning this is a cluster of defects that travel together in the context of an acronym for VACTERL, but that really have not been specifically consistently reported to have a genetic abnormality. There are a few sporadic cases associated with the genes that I've listed above, specifically with some overlap to things like the Fanconi anemia genes, but usually this is just a constellation of findings where you have at least 3 of them, including vertebral defects, anal atresia, cardiac defects, TE fistulas, renal malformations, and limb abnormalities. Even though this is typically not a hit as far as genetic testing, it's important to do it because you still really want to exclude the mimickers, the ones that look a lot like VACTERL but have significantly different recurrence risks associated with them. So here's a first trimester fetus actually with anal atresia. This is a common finding in the first trimester, lost later on, which is a dilated rectosigmoid colon that goes right to the level of the perineal skin. Radial ray defects are a hallmark of VACTERL syndrome, including here the typical clubbed hand or malpositioned hand due to an absent radius, but they can include really just about anything. I have a patient ongoing right now who herself has VACTERL, and the only abnormality she shows on an extremity is a missing thumb on her left hand. Again, any permutation of extremity abnormalities, but more commonly arms. Abnormalities in vertebrae can be significant, ranging from scoliosis and other major malformations to sometimes simple things like just a hemivertebrae, best obtained on skeletal renderings, but you may also have segmentation abnormalities with fused vertebrae or otherwise irregular vertebrae. Now, renal abnormalities can range from simple, like hydronephrosis, to more complex ones that require you to think a little bit. In this case, you can see the fetus is missing a kidney on the left side, has a larger single kidney on the right side, perfused by 2 renal arteries, and this is typical of cross-fused ectopia, where the typically left kidney has migrated towards the right with fusion of the kidneys and 2 specific arteries that are visualized. But they also include abnormalities like horseshoe kidneys, as you see here. Now, there's a VACTERL H syndrome, which includes all of the issues we've talked about previously, but also include severe hydrocephalus, which is often asymmetric. And here you can see there's really marked dilation of this left side of the brain. Now, Noonan syndrome, I'm going to talk about really as a cluster of abnormalities, but keeping in mind that Noonan syndrome itself is really a dominant disorder, mostly sporadic because we're seeing most of these children born to normal parents, with an incidence of 1 in 1,000 to 1 in 2,500, both genders equally affected. Now, the most published mutations are in the PTPN gene, which is located on 12q, but even Noonan panel testing, if you include the other genes that are associated with Noonan's, still gets you only about a 75 to 80% diagnosis rate for children ultimately deemed to be within the Noonan spectrum. But really, for the commonalities of these disorders or the Noonan spectrum, it's a disorder of the RAS mitogen activated protein kinase pathway, and they're collectively referred to as RASopathies. The common features include dysmorphic facies, short stature, webbed neck, lymphatic abnormalities, so they have a lot of crossover with Turner syndrome in the early trimester, but may include some other things that we can't typically pick up in a fetus, which include things like bleeding diatheses. As a group of cardiac abnormalities, they tend to be different from left-sided obstructive disease. Here's just really a good Venn diagram, which I have also included in the case I'm going to present. But these are all the Noonan spectrum disorders, so Noonan syndrome, craniofaciocutaneous, Costello syndrome, etc., and showing you where a lot of the phenotypic variations lie across those disorders. Now, cardiac anomalies are common in Noonan syndrome in 80 to 95%. Importantly, they may be progressive. The two things that are seen most frequently are a very typical type of pulmonary stenosis, which is due to a dysplastic valve that's rare outside of Noonan spectrum, which is seen in approximately 70%. And not to forget that these fetuses also may show cardiac hypertrophy or hypertrophic cardiomyopathy. The extracardiac features, again, some have a lot of overlap with Turner syndrome, and some are a little bit more specific, including umbilical or ductus abnormalities. So here's a baby I took care of a really long time ago who had a very large head with posteriorly rotated low-set ears. Here you can see the picture of the newborn with the same ear phenotype. This is an example of a persistent right umbilical vein. Here's the stomach bubble on the left. We see the umbilical vein come in to the right of the gallbladder and then curve back towards the stomach bubble. An abnormal insertion of the ductus venosus, particularly one that inserts low down on the inferior vena cava, is also a hallmark of Noonan syndrome. Here's a really good schematic from one of Rabbi Chowie's papers showing you that atypical ductal insertion. And again, not to forget the hypertrophic cardiomyopathy. Holt-Oram syndrome is also a common source of congenital heart disease. It's heart-hand syndrome or atriodigital syndrome. The most common features include congenital heart disease and radial ray defects. But remember that the penetrance can be really incomplete. You may have an individual who's affected with Holt-Oram syndrome who has a minor cardiac abnormality in the form of an undetected ASD and whose limb defect is a subtle carpal abnormality. So you can have somebody who you have not diagnosed with Holt-Oram syndrome, but who can have a child with significant structural abnormalities owing to greater penetrance of the disorder. So we're looking at minor defects that can range from things like triphalangeal thumb to more significant limb abnormalities, including complete phocomelia. And interestingly, the degree of limb deficit does not correlate with the complexity of the congenital heart disease. It's a heterozygous mutation in the TBX5 gene located on chromosome 12q, and it carries also a risk for cardiac conduction abnormalities as well. So here are some common features of Holt-Oram syndrome. You can see again radial ray. Here we have almost a complete phocomelia. Here is one of my earliest pictures of a triphalangeal thumb. You can see the three of them identified at the tips of the arrows here. And here's a 12-week fetus whose father fell into the first category I described. He was not identified as being affected with Holt-Oram syndrome, even though he had a tetralogy of Fallot repaired as a newborn. He was subsequently being proven to be affected by mutation analysis when he fathered a child with a limb abnormality and pulmonary stenosis. So here at the time of nuchal translucency, we were trying to assess this fetus's extremities and really had this sort of strange clefting on the left hand in a fetus who ultimately did prove to be affected. Now moving on to our final one, which I'm going to hope to get through quickly because of the time, is 22q deletion syndrome. Now this is the most common microdeletion syndrome that is known in humans, and really for younger maternal ages such as 20-22 is a more common disorder than a fetus with Down syndrome, but obviously we've focused most of our attention on the prenatal detection of Down syndrome. Now oftentimes 22q is used interchangeably with the term DeGeorge syndrome or velocardiofacial syndrome, but realize that they're not exactly synonymous. There are cases of DeGeorge syndrome that may be ascribed to other rare chromosomal defects aside from a 22q deletion. Now, if we're talking purely about the 22q syndrome, 90% of affected individuals have a really specific 3 megabyte deletion on 22q that includes over 30 known genes. This may be inherited more typically from a maternal lineage, but is really de novo in 80% of patients. Again, the most common deletion is this 3 megabase pair A to D deletion, which is seen in 97% of affected individuals. But there are also subtypes or nested deletions within this large 22q gene that may have different phenotypes depending on where the deletion occurs and what genes are affected. Again, there's 4 discrete blocks within the gene, A, B, C, and D, which include low copy repeats, and the characteristic deletion includes the full A to D spectrum. The second most common is the A to B. Now, phenotypic features are well reported for individuals with 22q as well as onset at development. In fetuses, these become a little bit more difficult because we really don't have the ability to look at things like immune function or velopharyngeal insufficiency. And really, most of the data has focused on things like cardiac anomalies and cleft palate. Now, I'm not going to get into these cardiac anomalies in detail due to many other lectures in this course, but really what people have not talked about in great length is the presence or absence of the thymus. It has been reported in many papers looking at thymus specifically, but not in terms of a large data or cohort overall. Now, just to go over the incidence of congenital heart disease, interrupted aortic arch has the highest risk of 22q, along with what you see going downwards here. Now, a soft palate cleft can be tricky to see in a fetus because, again, you're not looking at abnormalities where the lips and the palate, the hard palate, are a giveaway. You're trying to visualize something that's a dome-shaped structure surrounded by bowel, and it can be really hard to see well. There's lots of volume-based imaging modalities that can be helpful but require expertise. One of the simpler ways to look at it is really to look at the uvula, which is a surrogate of the integrity of the soft palate. In most individuals with a soft palate cleft, the uvula will be absent, so it won't be visualized on a 2D ultrasound. And this has been published roughly 10 years ago as something called the equal sign, where you're looking for 2 echogenic lines or an equals to identify the uvula for you in a grayscale image. Now, this requires a little bit of patience. You have to wait for the fetus to swallow. Here you can actually see the uvula shape itself, but here are the 2 echogenic lines as the equal sign. Here's a fetus where we waited and waited and waited with a TET MAPGA and no uvula appeared. And finally, here's one that I'll never get again in my life, which is a bifid uvula, again, in an affected fetus with 22q. Now, thymus evaluation can be direct, meaning you're looking at the thymus and mentally assessing that it's present. And that's easier to do in the 3rd trimester because it's much more prominent. In the 2nd trimester, it's not really as well defined from the surrounding tissue and can be tricky to look at. So in that case, we're going to be looking for surrogate measures. Now here in the 3rd trimester, you can see that the thymus is a little bit hypoechoic relative to surrounding lung fields, and you can pick it up pretty easily. And again, similar concept in front of the 3-vessel view in the 3rd trimester. In the 2nd trimester, this is not nearly as easy, and we have to look at surrogate ways to prove that there's thymus tissue present. One of the best ways that I know how to use and still use to this day is a simple ratio published about 9 years ago by Rabbi Chowie, looking at a thymic thoracic ratio, or a way to identify a tissue mass in front of the 3-vessel view that would really create a space-filling effect to document a normal thymus. The idea being if the thymus is present, it's going to create a specific distance between the border of the sternum and the anterior border of the aorta, and that can be defined as a distance relative to the AP diameter of the chest. And again, in his initial study, this segregated really well between normal fetuses with congenital heart disease and no 22q deletion, where that distance was just under halfway for the full diameter of the chest. But of fetuses with congenital heart disease and 22q, none of them were greater than 0.3, meaning the anterior border of the aorta was much closer to the anterior chest wall. Here again are two examples: normal diameter of 0.4, very small diameter of 0.22 in a fetus with tetralogy of Fallot. Now this diameter has been changed a little bit and reported as a slightly different ratio by Alfred. Instead of using the ratio to the anterior border of the aorta, he uses it to the anterior border of the brachiocephalic vein, feeling that that anatomy is better conserved in fetuses with conotruncal disease. But his data published shows exactly the same trend. In fetuses who have 22q deletion, the distance towards the brachiocephalic vein is much reduced as opposed to those who are normal and have congenital heart disease without a 22q deletion. Again, looking at a way to look at the thymus, you can use the internal thoracic or internal mammary arteries as a way to delimit the thymic capsule. This is published by Palladini, and typically these arteries will arise off the subclavian arteries bilaterally and join the chest wall anteriorly in a perfectly parallel or almost goalpost configuration. When the thymus is absent, the arteries are closer at their origin and then diverge as they get towards the chest wall. So looking at the thigh box, you're going to want to look for two arteries, as you can see here in red, which are perfectly parallel to each other. Finally, another marker published by Rabi and Alfred is looking at the cavum septum pellucidum in fetuses with 22q deletion. And this is a fetal extrapolation of data that was published in children with 22q, looking at both the width and the posterior extension of the cavum septum pellucidum overall for a volume measurement, but showing that the size and volume of the cavum was increased in children with 22q. Now, the ratio that we use at the level of a fetal ultrasound is really simple. It's a biparietal diameter measurement and a measurement of the cavum the same way you would do a nuchal translucency, for example, and looking at that ratio. So here we have our cavum to our biparietal diameter. In that report, we showed that the cavum septum pellucidum shows a linear correlation with biparietal diameter, meaning the width of the cavum increases as the fetus gets larger, so does the BPD. In fetuses with 22q, the cavum was larger than expected in 67% of affected fetuses with a z-score of 2.6 on average. But if you look at fetuses with a BPD of greater than 50 millimeters, which is roughly 20-21 weeks, 87% of affected fetuses will show a dilated CSP. So using a BPD cutoff of 50 millimeters, we see that this really segregates nicely between normals and abnormals and can be a helpful feature. I'm just going to finish this talk quickly with a patient that was referred to us a couple years ago for outside exam with choroid cysts. She was a 28-year-old who already had 2 prior children, including one that had already been diagnosed with learning disabilities and ADHD, as well as a subsequent family history of schizophrenia and congenital hearing loss. Because of the presence of choroid cysts, she opted for a 22q deletion as well as NIPT testing drawn. And this was the result that we got back, which was uninformative for the fetus specifically, but very suspicious for a maternal deletion in the 22q11 gene. When we did the maternal microarray, this patient showed an atypical, so not the typical A to D deletion, but a central microdeletion of the B to D element of the gene. So remember, that's one of those nested smaller deletions. Looking at this again schematically, here is the typical A to D deletion. Here is the B to D, or what this patient herself had. Now, if we look at this up close and personal, her B to D deletion included many of these specific genes, but look what's not included in that deletion. And that includes, the hallmark TBX1, which is really the gene felt to be most responsible for a lot of the conotruncal disease that's evident with this problem. In her area, we're looking more at cerebral dysgenesis, facial dysmorphism, and some other non-specific features that are not the typical 22q. Also pay attention here that most FISH probes, that if you're looking at a fetus for a FISH deletion, will look at the A to B region and would have missed this patient in the event that we used a FISH probe only for 22q on an amnio. The patient herself declined invasive testing, so we took one step back and plotted the BPD to cavum width in the second and third trimester and came up with these two values. So based on that alone, made the assumption that this was most likely an affected fetus, which actually turned out to be exactly the case. When the neonatal array was obtained, it mirrored mom's deletion precisely. Thank you.